So today I want to share with you enhancing understanding and training for hemoglobinopathies in pregnancy. My name is Joyce Adu-Amankwah. I'm a specialist hemoglobinopathies midwife at St. George's. What I'm going to share with you today is not going to include more detailed analysis of the condition, but we're going to go through a little bit onto that and a pathway of what to do in order that we can meet the needs of our patients who have hemoglobinopathy conditions. So the objectives I've got here is a brief introduction of hemoglobinopathies, statistics of sickle cell and thalassemia, complications of sickle cell disease and thalassemia disease, patient's journey. I put something there for that. Incorporating hemoglobinopathy training in midwifery and obstetric education, multidisciplinary training workshops, promote culturally competent and patient-centered care, advocate for policy change and service improvement, and utilizing data and research to drive change in care provision. So what is hemoglobinopathies? It's a big terminology that we may not be familiar with, but it's simple. The word hem is about the red blood cell. So hemoglobinopathies is conditions that affect the red blood cell. Now, the red blood cell, it lives for 120 days, and the role is to transport oxygen from the lungs to the tissues. And sickle cell disease affects the structure of the red blood cell, depriving it the efficiency of oxygen diffusion to the body. Thalassemia is affecting the production of the red blood cell. So there's a limit or the quantity of how much produce is reduced. So if the quantity is reduced or the limit is not up to the level, that means the patient is deprived of oxygen as well. These conditions is said to be developed from the chromosomes, which is the DNA that develop our bodies. So both conditions develop or come across from chromosome 11 and chromosome 16. It's just a little bit of genetic makeup in there. So why are we interested as midwife in hemoglobinopathies? One thing we have to know that our patients go through antenatal booking, and we don't mention so much, but looking after the mother and the baby, there's a lot of genetics involvement. Whatever the mother or the father has, any condition can be inherited. So sickle cell condition is the most common genetic inherited condition in the world. It can only happen when mother and father has the gene or they have the condition. They can pass it on to their offspring. So it's very important for us to know about it. That is why we do antenatal screening. And we have the guideline for screening pregnant women from 10 weeks gestation. This is important for sickle cell and thalassemia because from there we will be able to know and identify, is this patient or this baby going to be affected by sickle cell disease? The mother herself, is there any concern? So we can navigate the pathway for their care in the antenatal period. The statistics shows that in this UK here, in this country, we have approximately 17,500 individuals who are currently living with sickle cell disease. It's a very common disease, but it's most of the time the condition that we don't seem to understand the most. In each year in UK, about 300 babies are born with this condition. And we have to remember that these patients are growing up to become adults, and they are having children as well. This information is from the Sickle Cell Society, and that was done only last year. That is the current update. Approximately 1,000 patients are living with beta thalassemia, and between 20 to 30 parents are at the risk of having a baby affected by alpha thalassemia. Alpha thalassemia, that is the one that, for me as a specialist, it concerns me because this condition, particularly the alpha thalassemia, is not compatible to life. And if it is not diagnosed, and the mother who is carrying the baby, who is affected by fetal hydrops or the alpha thalassemia major, she also has 50% chance of maternal death. So it's very important that we know about this condition and we know about the patients we are caring for. So what is sickle cell and pregnancy? Sickle cell has an effect on the pregnancy, and the pregnancy has effect on the condition. So you may have a patient who is sickle cell, have not expressed or show any symptoms or any kind of condition at all. And you may think that this one is sickle cell, but she's not exhibiting any symptoms. But once they become pregnant, they become high risk. And subsequently, they can bring on issues that need to be addressed. Some of the conditions that can affect them or can appear in pregnancy, their miscarriage rate is very high. They can have miscarriage. So if we are looking, like there was a patient who had 2 pregnancies and she's in her 40s. She went to early pregnancy unit and she was told that they cannot refer her to consultant because she needs to have a 3rd pregnancy loss before they refer. No, you don't leave sickle cell patients in that sense, because their miscarriage rate is over 25%. So a patient like that needs to be referred for consultant review. We must be extra vigilant with these patients when something happens. It is important to identify it and address it immediately. Otherwise, it can exacerbate. They have preterm deliveries, 13%. Stillbirth is high. All other conditions, they can develop preeclampsia. It's very common for them to develop preeclampsia. And it's important for us to know their blood pressure. It may not be the majority blood pressure that goes over 140. For them, they may be normal for them, but you may see that there's a little bit of changes. It's worth keeping an eye on. Has she got proteinuria? Has she got anything else that needs to be attended to? So it's very important that we look after these women, not in the same way as we look after everybody. I mean, there are certain things that will not match. So it's important to have that extra attention and identify when something is about to go wrong with sickle cell patients. So is the same with the thalassemia. Beta thalassemia major, who may be on transfusion, and you may have somebody who is beta thalassemia intermediate. Intermediate means they may not be on transfusion throughout their lives, but when they are pregnant or when they are sick, they need to have transfusion. This is about beta thalassemia major, those that have to be transfused every 2 to 3 weeks of their lives. That's what is keeping them. They have a high rate of having diabetes, obstetric cholestasis, growth restriction, there are cardiac problems in the pregnancy. So it's very important to update our knowledge about these patients. So when they come through the door of our care, we know and we look after them. If something happens, we know what is happening. We understand what is happening and refer them appropriately. So this is Nana. You may not see a lot of it, but I'm just going to talk you through about this lady. It's just like a pathway. So this lady, his name changed. I just put that there as Nana. She started her antenatal booking at 10 weeks gestation. And then she had antenatal blood booking, blood taken for antenatal screening. And it came back that she was sickle cell disease that she had not known. Previously, where she's coming from, she's been reporting that she has joint pain, but attention wasn't paid there and she wasn't diagnosed until she became pregnant here. Then diagnosis established. So now she came through the door as low risk, but because of the diagnosis, she's no more no risk. She was handed over to specialist team to look after her. But what I want to draw attention is that it's not just the specialist team if you have a specialist team. It's not just the specialist team that will care for this woman. This woman went through low risk booking. Then she has been through to 16 weeks gestation after. That's when they realized and they referred her. At the 16 weeks, she's been through with midwife, low risk midwife as well. At that time, a lot of things that needed to be educated. She needed education on the condition and also on the pregnancy. But that got missed until she saw the specialist midwife. So there is importance. Then she went to day assessment unit, fetal medicine unit for all the scans. And then it came to a time when she had a preeclampsia. Then she had a growth restriction. So she's gone through the assessment unit also for fetal monitoring because of reduced fetal movement. So if you look at the system step by step, she's going through every angle of the maternity clinic that we have or the wards we have. She was admitted. She went to triage as well with reduced fetal movement or query SHROM. She went to labor ward for delivery. And then she went to postnatal ward after delivery. So, and then baby has to be screened as well. So if you take this woman's journey, everywhere that she has been, she see a midwife. So this is very important for us that what is happening to the woman, we are very much aware of it and know how to deal with it. And then we have a team that you could also communicate with, referral to hematologists and all that. So it's very important as midwives to have a knowledge and understanding of hemoglobinopathies because we constantly deal with them. We cannot say that we don't deal with them. We deal with them right from antenatal booking, antenatal care pathway, day assessment unit, triage, labor ward, postnatal ward. So we need to educate ourselves and know how to look after these women in order to address health inequalities. So how do we go about that? It's very important to incorporate training into the midwifery training, doctors training, obstetricians training. It's very important for us to have that education if we are going to meet the needs of these patients. It's also important to have mandatory training that also meets the need and help us to understand and update our knowledge about sickle cell and thalassemia. We need to utilize case studies, patient narratives, and real-life scenarios to enhance our practice, our education and practice. That below is some references. We need to conduct multidisciplinary training workshops and webinars, particularly in the areas or the hospital or maternity unit where there are a higher number of these patients coming through to our services. So we need to facilitate multidisciplinary workshops, organize interactive webinars and virtual learning sessions together with the hematologists and obstetricians as we do in our simulations in order to understand the process when they have come, these patients have come to labor ward and having crisis in labor, we know how to deal with it. The antenatal booking, we know the information, we may know information now, what we have to give, but if there's a problem arises, do we know how to deal with them? It's not only sickle cell. We are talking about thalassemia as well. We are talking about alpha thalassemia as well. Now, let me mention this. The alpha thalassemia takes longer to identify. It is the one that, for me, I fear most. Because the alpha thalassemia, we tend to have blood results that says possible alpha thalassemia. How do we then identify that this lady or this pregnancy is at risk of alpha thalassemia major? So we need to update which group of people are at risk of alpha thalassemia major. And it's not just that, there's more complexity. It takes about 10 weeks to do a DNA testing and get a result. So let's say the woman has come through, she's booked a 10 weeks gestation, and the results came, and she's possible alpha thalassemia, and she's from Southeast Asia, because that is where the higher risk of alpha thalassemia is. She's from Southeast Asia, and we have, from the specialist and genetic counseling, she needs to have a DNA to confirm if she has alpha 0. That puts the baby at risk. Both her and her partner needs to be tested. And they've both tested. Remember, the partner needs to come for test. in order that for them to have the DNA testing, if both parents are alpha thalassemia carriers, if it comes as possible alpha, they need to have a further testing, which is the DNA, which will confirm that if they are both alpha 0, and if they are both alpha 0, the chances of them having a baby with fetal hydrops or alpha thalassemia major is 1 in 4, which is high risk. So we need to, and that's DNA testing takes 10 weeks to get the results. So when we say early screening, it's very important for midwifery. These women may not come at 10 weeks gestation. Most of the time, sometimes they come about 12 and all that. Whatever time they come in, we have to facilitate their care so fast so that we can get best results for them. So it's very important for midwives to be aware of this one. But if we don't have the knowledge of it, if we don't have understanding of it, we will just put them through. And by the time we get to them, it may be too late. We need to improve screening as well, and risk assessment competencies. It's very important. We need to try and do more to put hemoglobinopathy conditions on the line that is every midwife's responsibility. We need to ensure that every midwife understands how to interpret hemoglobinopathy test results, because then you'll be able to refer appropriately. And let's see here. We need to promote culturally competent and patient-centered care, because this condition is not just a condition, they are coming with psychosocial issues as well, that normally we tend to look at more clinical side, but the psychosocial issues have impact on their condition, as well as the condition may have issues for their psychosocial system as well. So it's important for us to know, educate ourselves in all of this, and implement cultural competency in our practice. So educate midwives on health inequalities and racial disparities. Encourage personalized care plan that respect cultural beliefs, because the decision they will make is based on either their religion or their culture, where they are coming from. And when you're doing genetic counseling, you can hear different types of informed consent, informed decisions. That is when these things comes in, because most people make decisions based on their religion, based on their culture. And it takes time to come to the point for them to realize the importance of them having to go ahead with the screening and pre-diagnostic testing. So that's what I have to mention as midwives. It's important for us to be starting educating, knowing about this condition right from the start of our training. We need to develop language accessible resources for patients from diverse backgrounds. So we need to utilize data and research to drive a change. This is very important for improving maternity care. Assess midwives' knowledge gaps and training needs, evidence-based research, and collaboration with universities and research institutes. Recently, I was on a Capital Midwife course, and I did a project that's testing for midwives' knowledge and understanding on hemoglobinopathies. And 10% responded out of 250 midwives. And within that, 100% said yes, they agree that hemoglobinopathy condition is every midwife's responsibility. And they also confirmed that the further training is required. So this is where today's presentation is about, that is every midwife's responsibility. Like diabetes, we have learned a lot about diabetes. So we need to learn a lot about hemoglobinopathies. It's a sickle cell and thalassemia. There is more than the alpha thalassemia and beta thalassemia. There is more, but these sickle cell thalassemias are the two major conditions. And that is why it's important for us to know, and because they are coming through, the patients are coming through us, and they are going sometimes without understanding, or, they are not cooperating. Because if we cannot explain to them what is going to happen, they cannot cooperate with us. So in conclusion, I would say enhancing midwifery education on hemoglobinopathy in pregnancy will lead to better maternal and fetal outcomes, safe pregnancies, improve patient experience, quality improvement services for them, and addressing inequalities in health for hemoglobinopathy patients. Thank you very much for having me.